Good afternoon. Welcome to Grand Rounds. It's my pleasure today to introduce Carol Watson to you. Carol's a professor of medicine. She's the director of the UCLA Barbara Streisand Women's Heart Health Program and also the director of the Cardiology Fellowship Program there. She did her undergraduate work at Stanford Medical School at Harvard, where she graduated magna cum laude, residency and fellowship at UCLA, and she was in the STAR program there. That's the specialty training in academic research, where she got her PhD in physiology. She's an associate editor of Circulation. She's currently the PI or co-PI on 3 NIH grants. She has numerous honors and awards that I won't detail, but I found one quite interesting. There's a lot of these best doctor lists. 5280 Best Doctor Company, U.S. World and U.S. News and World Report Best Doctors. In Southern California, they appoint super doctors, and she's been appointed as a super doctor for several years. So that's way better than Best Doctors, and we're delighted she's here. And thank you for coming. We're looking forward to your talk, Heart Disease in Women, New Insights into the Differences.
Well, thank you very much for that introduction. Yeah, I have no idea how you get to be a super doctor or what it entails, but I don't know. So I'm happy to talk to you today about heart disease in women. It's one of my favorite things to talk about. And what I really think I would like to leave you with is that we're mostly the same. Women aren't weird or aliens or anything, but there are some important differences. And the devil's in the details. So I think when we pay more attention to the differences, I think that's when care gets better. I have no disclosures relevant. So my undergraduate degree was in history at Stanford, and I found out about a lot of you guys as undergraduate. That's why I'm always interested. So I'm always interested in figuring out the historical underpinnings of things. So we know that heart disease in women wasn't always appreciated. So I wanted to figure out how that started and when we got off track. And I was really surprised to see that it was as early as 1964 that the AHA held the very first conference on women and heart disease. And it had the leading cardiologist of its day, Dr. Paul Dudley White, be the keynote speaker. Fabulous, right? That's actually you can find anything on the internet. That's actually the actual invitation that was in the newspaper. So I looked at that and I realized it wasn't exactly what it seemed because it was entitled Hearts and Husbands. That made me a little suspicious. Then I read the fine print and it was basically how to care for your man. It said, this session has quote unquote vital importance for the wives of men suffering from any heart disease. And there was no discussion of women and heart disease at all. But that was 1964. That's ancient history. So jump forward. And in 1995, Reader's Digest was still asking women to protect their husbands' hearts. And then, again, no discussion of self-care at all. So here we are in 1995, still not thinking of women as being at risk, even though we know full and well now that we are. Well, jump forward, 2015. It's getting better. We now understand that heart disease in women is a real thing. Women are at risk, but The Atlantic wonders why doctors still misunderstand heart disease in women. And I think that's a really good question. I think part of the problem, and I actually took this out of my talk at the last minute due to time, but part of the problem is when you look at clinical trials, virtually everything we know in cardiology comes from our clinical trials. And Table 1, which is the description of who gets enrolled in clinical trials, in virtually every cardiovascular clinical trial will look exactly the same. It'll be a 64 to 67-year-old chubby white male. And that's why we know so much about that guy. Not as many women, not as many ethnic minorities and other people of interest. So we don't understand a lot about heart disease in women because women have not been studied as much. So I want to talk about scope of the problem. Then we'll talk about prevention because I think that's the only way we're really going to attack any of these epidemics. Talk about differential impact of risk factors. differential responses to medications, then interventions, how myocardial ischemia presents in men and women, and then how there are differences that we've determined in the pathophysiology and in the outcomes. And then I wanted to just finish up briefly with some of the research from our center. So, scope of the problem. This is from the most recent AHA heart disease and stroke statistics. So cardiovascular disease mortality trends for both men in blue and women in red from 1979 to 2013. So what you can see is at around 1984, women started to outstrip men in total deaths from heart disease in this country. It stayed that way and peaked at around 1995. And then has steadily come down pretty dramatically, such that now there's parity. As many women are dying of heart disease as are men in 2016. That's sort of good news, except the fact that it's unacceptably high in both men and women. And when you look at leading causes of death for women, this is what it looks like. Heart disease is by far and away the #1 cause of death, followed by cancer, and then a number of other things. But heart disease and cancer are way up here, and everything else is way down below. Women have so many complexities in thinking about different healthcare concerns, different ways of prevention, and things like that. As many of you know, women are very concerned about cancer, and in particular, breast cancer. But when you look at the actual numbers, breast cancer is a smaller segment of the deaths in women. And when you compare the numbers, about 40,000 women per year dying of breast cancer in 2013, compared to almost 300,000 women dying of heart disease, you can see the woman's major threat to life is heart disease. And a lot of people say, yeah, well, it's just really old women who die of heart disease, and that's not true at all. Almost every decade of life, heart disease is the #1 killer of women, and especially in women from the age of 40 on. You can see that heart disease, shown as the red line, greatly outstrips anything else as a cause of mortality. So we know heart disease is the #1 killer of women in this country. It takes more lives than all forms of cancer put together. And again, women are not different aliens so that everything we know about heart disease has to be specifically tailored to women. Most approaches, however, have been developed in men and really not always validated in women. There are many similarities, but there's a lot of differences. And we think that the differences are important, and that's the goal of our research in our center. So let's talk about prevention and how women and men may differ. So first, I'll talk about differential impact of risk factors and then differential response to medications. Risk factors tend to be operative in everyone. So risk factors for a man tend to be risk factors in women, et cetera. But the relative strength of the association or the importance of a risk factor may differ. So a lot of what we know comes from large observational or case control studies like this study, the InnerHeart study. This was a very large study done by Salim Youssef in 52 different countries across the world. 12,000 cases, 14,000 controls, looking at predictors of first myocardial infarction. So they looked at predictors such as smoking, diabetes, physical activity, lipids, obesity, alcohol intake, hypertension, diet, and psychosocial factors. We ran for 4 years between 1999 and 2003, and here's what they found. When you look at who got a myocardial infarction, these 9 risk factors really did explain most of it, about 90% of the population attributable risk. Some of these were bad. So up there in the red box, smoking, obviously bad. Having abnormal lipids, high LDL, low HDL, bad. Hypertension, bad. Diabetes, abdominal obesity, and psychosocial stressors were all bad. Some things were good, like fruit and vegetable intake, regular alcohol intake, and by that they just define that as at least 1 drink a week, and regular physical activity. But when you look at the differences by sex, you see some there. So for instance, diabetes was bad for everyone, but it was a lot worse for women. Hypertension, bad for everyone, but again, a lot worse for women. So let's look at these two. I'm going to start with hypertension. So this is what blood pressure trajectories look like pretty much in everyone. This is data from Framingham, or from NHANES, I'm sorry. And what it shows is that sort of every year of our life, our systolic blood pressure just marches up and up and up and up. Our diastolics march up until about the age of 60, and then they start going down. In men, it's a nice smooth transition up. In women, there's a nice smooth transition until about the time of the menopause, when there's an increased risk of hypertension, and it sort of bumps up, but then it goes up from there. So, but from the time of menopause onward, women have more hypertension than men, as you can see here. So before that time, men seem to outstrip women in hypertension prevalence, but from the age of about 55 on, women have more hypertension than men. And the population attributable risk for hypertension is greater for women than it is for men. That means how much of heart disease can you blame on hypertension? Diabetes, we've known for a long time, it's very bad for everyone. It's really bad for women. So this is data from Framingham. We learned this a long time ago. If you look at the relative risk over an individual of the same age, gender, everything else match, one who has diabetes will have a risk of having cardiovascular disease that's about 4-fold higher for women, about 3-fold higher for men, higher risk of heart disease, coronary heart disease compared to women compared to men, higher risk of heart failure in women compared to men, intermittent claudication. The only thing that went the other direction was stroke, where men seem to have a higher risk comparatively than women. But when we used to think it was just diabetes. So a woman who gets diabetes is really at high risk. We know that. But we now know it's much earlier and much more widespread than that. So it appears that anything related to insulin resistance is a much higher risk for women as compared to men. Take high triglycerides, for instance. The risk to women as compared to men is higher. Take low HDL. Having low HDL is a worse risk factor for women than men. Take insulin resistance. It seems to be worse for women than men. Even take something as simple as carbohydrate diet intake, glycemic index. So, glycemic index is just a measure of how fast the carbohydrate that goes in your mouth shows up as glucose in your bloodstream. So it's basically a measure of the effects of a standard dose of carbohydrate, usually 50 grams, on blood glucose levels, compared to the effect of like 50 grams of, white bread or glucose drink. And so if you have a low glycemic index, that's something that releases glucose very slowly into your system, versus a high glycemic index food, which is basically immediately, as soon as you eat it, it shows up in your bloodstream as glucose. So instead of looked at carbohydrate intake and coronary disease or heart disease risk, many of them have shown that carbohydrate excess is associated with increased heart disease risk. And in fact, this study shows that how high glycemic index carbohydrates are significantly associated with heart disease risk in women, but not men. So in this study, they looked at the carbohydrate intake amongst men versus low glycemic index foods versus high glycemic index foods. And you can see if you're in the different quartiles of low glycemic food intake, it just didn't matter. Whether you're in the lowest intake or the highest, there was no relationship to heart disease. Same was true for high glycemic index foods for men. Whether you're in the lowest intake or the highest intake, quartile 1 or quartile 4, just no relationship. When you look at women, though, it's a different story. Women who took a lot of low glycemic index carbohydrates in, it just didn't matter. Again, if you're in quartile 1 or quartile 4, it just didn't matter. But if you took in a lot of high glycemic index foods, the quartile 4 versus quartile 1, there was a direct linear increase, and that was statistically significant. So all things related to insulin resistance seem to be more impactful for women as compared to men, and because much of our cardiovascular disease epidemics of the future, I do strongly believe, will be driven by insulin resistance. It's a strong hunch that women are going to pay a higher toll. And I'm frozen here. Can someone help me get unfrozen? Oh, I can just...
working now?
Nope.
You could tap that.
There you go. Okay. Okay, so we talked about diabetes and hypertension as being more harmful for women relatively in this study. Let's talk about the good news. The good news is that exercise appeared to be more beneficial for women as compared to men, lower risk of having an acute MI, as did regular alcohol intake. Regular alcohol intake is something that is a double-edged sword for women, and I'll show you why. So many different observational studies have shown this J-shaped relationship between alcohol intake and mortality. So the pure teetotalers have a higher risk of total mortality than those who indulge just a little bit. And the nadir appears to be about 5 grams of alcohol per day. And it's all good, and it goes get a little less benefit the more alcohol you take in, and it's completely gone if you take in more than 40 grams of alcohol per day, and it goes straight up from there. 5 grams a day is about half a drink per day. 40 grams a day is about 3 drinks per day. And most of this reduction is due to reduction in cardiovascular death, and this is observational data. Now, this was a meta-analysis of 34 different studies, over 1 million people, and many different studies have shown similar relationship, so it's not unique. But looking at this very same study, again, 1 million people, we see that even though there's a reduction in heart disease mortality, if you take in these low levels of alcohol, there doesn't really appear to be any safe level of alcohol intake at which breast cancer mortality doesn't increase. So this is looking at pooled analysis of different cohort studies, women who took alcohol in, and you see the risk of having breast cancer goes up even at that very low intake of 5 grams per day. So when women, a lot of them think that taking that 1 drink a day is okay and is good, but we have to counsel them that, listen, while it might be good for coronary heart disease or heart disease mortality, it may increase the risk of breast cancer. And we've never found an intake of alcohol which is protective or not harmful for breast cancer. The other thing, again, the same cohort, the same analysis looking at 1 million different subjects, if you overindulge in alcohol, that means more than that 3 drinks per day, this is the penalty that men pay. So they have an increased risk going up to 80 grams per day. That's 6 drinks per day. And it goes up, it's statistically significant and it's important. But here's the penalty that women pay. So women pay a bigger penalty for overindulging than do men. So that's another one of the complexities, and it probably has to do with body size and things like that. But what we need to make sure we counsel our patients is to stay within what we think are those acceptable limits of alcohol intake. Now, those are the standard risk factors for heart disease that you see above, all the things we know: smoking, diabetes, high cholesterol, hypertension, obesity, overweight, physical inactivity, family history, and age. But below are some risk factors that are either far more pronounced in women or strictly only happen in women. Autoimmune diseases, much more common in women than men. So rheumatoid arthritis, lupus, all those things that we know are increased risks for heart disease. These are overrepresented in women. Breast cancer treatments. Women who've undergone breast cancer treatments, either chemotherapy or radiation therapy, have an increased risk of coronary disease that lasts really throughout their life. What I call the SAD risk factors, stress, anxiety, and depression, appear to be bigger risk factors for women as compared to men. And I'm going to talk specifically about stress and anxiety at the end. And then pregnancy complications. So for a while, we used to say, if someone gets pregnancy-induced hypertension, then the treatment is just deliver the baby and then it's all fine. Everything goes back to normal. Same thing with gestational diabetes. But we understand now that these are risks that do indicate abnormal vascular reactivity, abnormal glucose metabolism. These are things that don't just go away because you deliver the baby. They're still there. They may not be as manifest immediately, but they are at greater risk for lifelong of developing hypertension, diabetes, etc. So this is data, Kaplan-Meier curve, looking at cardiovascular disease and coronary disease of women with and without gestational diabetes. And what you can see is that if you have gestational diabetes, shown here, you have much higher risk, lower event-free survival than women who never had gestational diabetes. And what's important to think mean, this is a timeline that goes from 0 to 14 years, but these are young women. These are women who are of their childbearing ages. So having gestational diabetes is a significant risk for future cardiovascular events, as is preterm birth. So the placenta is a big bundle of endothelium, and if you have abnormal placental function, which may lead to preterm birth, it does indicate that this is someone who probably has endothelial dysfunction in other vascular beds. So in women, this is a study that was published in Circulation earlier this year. In women who deliver a preterm child before 37 weeks, they have a slightly increased risk of having future myocardial infarction or stroke. But if you deliver a very preterm child, less than 32 weeks of gestational age, they have almost a 2.25 increased risk of having a future MI or stroke. So again, evidence of vascular endothelial dysfunction in one vascular bed tells you that there probably is endothelial and vascular dysfunction in another vascular bed, in this case, the heart and the brain. So preeclampsia with preterm delivery, about an 8-fold increased risk of future cardiovascular death, 5-fold increased risk of future stroke. If you have a full-term delivery, then things aren't as bad, but they're still not good. 3-fold increased risk of future death from cardiovascular disease, and gestational diabetes increases the risk of future cardiovascular disease death about 30%. About 20 to 60% of those women will develop true type 2 diabetes in the next 5 to 15 years. Okay, let's talk about preventive medications. Our two most important preventive medications are aspirin and statins, so let's talk about that. So if you think about myocardial infarction and talk about data in men, this is only in men, looking at 5 different interventional studies of men given primary prevention low-dose aspirin, it shows that there's a decreased risk of myocardial infarction. That's why we started decades ago recommending aspirin for all men over the age of 50, just a low dose, 81 milligrams. That's all you need. Aspirin was clearly better. We applied that data to women for decades until we finally did a definitive study in women. And this is what we saw. Taking 3 primary prevention studies together in women, there's just no effect at all, no difference. Now, it may be a dose-response relationship because in the women, those studies all used a lower dose of aspirin based on their lower body size, but we don't know. We just know that there was a definite decrease in myocardial infarctions in men with preventive aspirin and not seen in women. What about stroke? Well, if you look at those same studies and the effect on stroke of low-dose aspirin in men, there's really no benefit. It looks like there's no difference or even a slight trend towards harm. If you look at women, however, it's exactly the opposite. Women had a statistically significant reduction in stroke given low-dose aspirin therapy. What's interesting is that middle-aged men have many more heart attacks than strokes, while middle-aged women have many more strokes than heart attacks. So it appears that whatever is the vulnerable vascular bed appeared to have beneficial response to aspirin, but we don't know why, we don't know exactly the right dose, and we don't know what are the true pathophysiologic mechanisms. Statins, however, really in all the primary prevention trials show a consistent benefit if you have a high enough baseline risk of statin therapy in women, just as we've seen in men. Okay, so let's talk about interventions. First, how myocardial ischemia presents in men versus women, and then differences in the pathophysiology. So many of you may be familiar with this very iconic classic photograph from Frank Netter of a myocardial infarction. That's what it looks like. It looks like this hard-charging executive man who clutches his chest, falls to his knees. That's an MI. And he didn't make this up. This was actually well described by Sir William Osler in the late 19th century. It's a keen and ambitious man whose engine is always full speed ahead who gets heart attacks. So we, for a long time, thought of this really, very classic male picture of ischemia. But we've now seen in study after study that in women it looks different. So this is Chest pain is usually a feature of myocardial infarction in both men and women, but in women, it may not be the prominent feature. They may come in describing upper abdominal pain, shortness of breath, breaking out in cold sweat. Unusual unexplained fatigue was the most common symptom in a recent analysis of prodromal symptoms in women having myocardial infarction. How many of us haven't felt unduly fatigued in the past? So lightheadedness, sudden dizziness, nausea, really common. And this may have to do with how the pathophysiology of coronary disease is different in women versus men. In men, you tend to see a very focal stenosis that plaque ruptures, causes a myocardial infarction, and that's easy to detect on an angiogram. You'll see that type of stenosis, full limiting lesion, FFR, whatever, that's your MI. In women, what you tend to get is a more subtle, diffuse buildup of atherosclerosis throughout the vascular tree. And when you look at that vessel on an angiogram, it may look like just a small vessel. It may not look like anything to write home about. And these women used to be told, hey, everything looks great, you're fine, patted on the back and sent home. But we know from many studies that these women aren't fine. So this is data from the Women's Ischemia Syndrome Evaluation, the WISE study. And in this study, they had women who had a clinically indicated angiogram. Most of these were for chest pain. And they followed them up for years. They did a number of things looking for microvascular dysfunction as well. But one of the most important things they saw was that if you had chest pain, whether you did or did not have coronary disease, your outcomes were bad. So when you have coronary disease, that's shown the women with coronary disease and chest pain are shown in red, with coronary disease and without chest pain are shown blue. It just didn't matter. They just didn't do as well. But in the women who had chest pain, but if you had no obstructive disease, no chest pain with coronary disease, you did better than women who had chest pain and coronary disease. Does that make sense? So the only difference between these top two lines is the presence of chest pain. They had angiograms that looked almost the same, yet the women who had chest pain had almost 90% increased risk of cardiovascular events. These weren't just subtle events. They were hard events like unstable angina and MIs. And this is a different study that showed that women with acute coronary syndromes are more likely to have quote-unquote normal coronary arteries than men. So in this study, looking at unstable angina, almost a third of the women in that study with unstable angina had quote-unquote normal coronary arteries. Compare that to only about 14% of the men. In terms of ST elevation MI, true infarcts, about 10% of the women in the study had normal coronary arteries. Compare that to about 7% of the men. So acute coronary syndrome in the presence of normal coronary arteries is more common in women. What's going on? We don't know. So while coronary obstruction appears to be the operative role in men more often than women, coronary dysfunction appears to be equally as important in women. So that could be microvascular dysfunction, that could be coronary vasospasm, a lot of things, but a number of women with quote-unquote normal coronary arteries are having events. The microvasculature is very important. We ignore it. So when we do an angiogram, we see the large epicardial coronary arteries. That is about 40% of myocardial blood flow. But about 60% of myocardial blood flow is actually carried in the microvessels. And this is what it looks like. This is what we see on the angiogram. This is what you see if you do a cast of the microvessels. A huge, important network below. And it appears to be that women have more microvascular dysfunction than do men. And that may be really operative in what's going on in diabetes. Diabetes is known to be a defect in microvascular function. So women who have more damage or more harm from diabetes than do men also are known to have more microvascular dysfunction than men, and those two may be related. So women with non-obstructive coronary disease and stress abnormalities are at an increased risk for cardiovascular disease. Coronary disease also may be more difficult to spot in women. Symptoms are different. They're what we call atypical and often associated with different triggers. So many studies have shown that any stress, any chest pain that comes out with stress, whether it's emotional or physical, and goes away with rest, has to be considered to be cardiac disease. It turns out that women tend to have more chest pain, ischemia, from mental stress than men do, while men tend to have more from physical stress than women do. But evaluation for ischemic heart disease in women has to consider coronary obstruction, for sure, but also coronary dysfunction. All right, and I just want to finish up by talking about some of the research that comes out of our center. We're really interested in stress in the heart. And, you know, stress is something that really did not get a lot of attention for a lot of years. And a lot of recent studies in reputable journals have shown that it's a real thing here. So I live in California. We have a lot of earthquakes, and there was one huge earthquake called the Northridge earthquake. It happened on January 17 in 1994. So a very smart person did an analysis looking at the number of cardiac deaths in the Los Angeles area on January 17th in different years. So let's look at January in 1991. Every day there was about 40 heart attacks per day. If you look at 1992, again, about 40 cardiac deaths per day. 1993, the same 40 cardiac deaths per day. 1994, the day of the earthquake, January 17th, there were almost threefold higher risk. That's a huge stressor. This is an earthquake. Yeah, I get it. It's really stressful. But what about less stressful events like World Cup soccer? So if you happen to be a soccer fan, as my family is, they take it really a little bit too seriously. And in Germany, they take it really, really seriously. So this is looking at the number of cardiac deaths surrounding the World Cup in Germany in 2003, 2005, and 2006. 2006, the World Cup was held on German soil. Apparently that was a big deal. So if you look at the numbered spikes, 1 through 7, those are days Germany played a match. And you can see the other days, there's really no difference in cardiac deaths. Everybody's going along just feeling fine. But when Germany was playing a match, there was a spike in cardiovascular events. And on the days, the number 5 and number 6, as you see here and here, that was a particularly tight game. And that was a game where they actually got knocked out. The final was held down here. They didn't really care. It was Italy and France. They didn't care so much. But the game where there was a really tight, semifinal, increased risk. So stress is something that I can't tell you whether you're stressed or not. Only you can, and your body can decide. So stress in all of its forms can increase cardiac risk. Oops, sorry. So we know that when it comes to effects of stress on the heart, women do appear to be at a greater risk. In many studies, they've shown that heart attacks in young women may be precipitated by stress more often than men, and women also appear to be more vulnerable to heart damage from stress. Take, for instance, Takotsubo's cardiomyopathy. That's obviously someone presents like an acute coronary syndrome, but you take them to the cath lab, they have totally open coronary arteries, but they have this octopus vase-shaped heart from a distal, big akinetic apex. 90% of these cases occur in postmenopausal females, and they are most often preceded by a lifetime stressor, death of a spouse or child or something like that. So stress has a particular significance to women. And this is a study that was published in Circuit about a year ago. It looked at women and men who had known anxiety. They looked at perfusion studies, and these women and men, and what you can see is, frank perfusion abnormalities in individuals with anxiety. If you're a woman without anxiety, you had lower percent of ischemia than women with anxiety, and that was statistically significant. For the men, whether or not they had a history of anxiety, it didn't appear to make a difference. But women with anxiety were at greater risk, just like women who have acutely stressful events. So this is a cartoon I found when I was in a first-year fellow, and I thought, that's so cute. But then I didn't realize how actually true it was. So we wanted to make the stress test as realistic as possible, because it's not just physical stressors that cause ischemia in women, but emotional stressors as well. So when it comes to effects of stress on the heart, women appear to be greater risk. And again, like I said, heart attacks in young women may be precipitated more by stress than men, and also the damage like Takotsuba's cardiomyopathy. So we really wanted to understand potential sex differences in stress hormone levels as an indicator of the amount of stress. So we measured stress hormone in urine of men and women and compared the results. To do this, we used data from the cohort of individuals enrolled in the multi-ethnic study of atherosclerosis, MESA. MESA is a large observational cohort study that's sponsored by the NHLBI, and it basically was initiated to be sort of an update of Framingham. So Framingham Heart Study, very important, but it really does look at a cohort of individuals living in Framingham, Massachusetts, which is a little tiny town. So to make it more ethnically relevant, MESA was initiated to be a quarter black, a quarter white, a quarter Chinese, and a quarter Hispanic. And we have 6 field centers around the country, as you see there. And so what we did was we got these individuals together. This was on a random day that they showed up for their exam, not a high-stress day, just a random Tuesday or Wednesday or Thursday, whatever, and measured stress hormone levels. And what we found was that the men tended to be more likely smokers. They had higher diastolic blood pressures, and they had lower HDL cholesterol levels. The women were more likely to take antihypertensive medication and be overweight or obese, but when we looked at their urinary catecholamine levels, we found that norepinephrine was significantly higher in women as compared to men. The other epinephrine and cortisol were not different between men and women. Now, we know norepinephrine has been associated with increased coronary calcium and increased cardiac events. Dopamine sort of appears to be like the antidote to norepinephrine. It's like the happy hormone. And we found women have higher dopamine levels, which are associated with lower cardiovascular event rates. So women are a mixed bag. Higher stress hormones, but higher happy hormones. I don't know. So we don't know where that will leave them in the realm of cardiac events, but it's probably significant. And the other thing we recently published on is air pollution. And I live in Los Angeles, so you can understand my interest in air pollution. So air pollution is bad for a lot of reasons. It looks bad, it smells bad, but it's really bad because the particulate matter it contains. So particulate matter, those are those little tiny microparticles that you breathe in. If you can see it, you're breathing it in. If you can smell it, you're breathing it in. And they're really tiny. So this is compared to a human hair. If you look at the microparticles we're talking about, they're PM2.5. They're so much smaller than a human hair. They're tiny. You don't know that you're breathing them in every day, but if there's any particulate matter in the air, you are. So what happens is there's all sorts of fixed sources, factories, cars, emissions, everything. You're breathing it in. Many of the big particles are filtered out by our defense mechanisms, our cilia, but those microparticles can just get sucked deep down into our lungs, cause inflammation, cause cardiac events. Most people think about air pollution in terms of its respiratory effects, but we're interested in its cardiovascular effects. So we published this paper in The Lancet last year, the association between air pollution and coronary artery calcium within 6 metropolitan areas in the U.S. The MESA study is a longitudinal cohort study. And so what we did was we put mobile air monitoring devices in people's houses. So we did about 100 homes in a number of different cities, and we monitor them in 2 different seasons. So you have to monitor them in summer when there's outdoor barbecues and things like that, and in winter when the fireplace is going. So you have different particulate matter burdens in different seasons. And so the 2-season monitoring occurred in about 100 homes per city. And then a subset of those who had outdoor monitoring, we had home monitors too. So we told them to put whatever is the most commonly used room in your house. Sometimes it's the kitchen, sometimes the living room. Put the monitor there and see what the air pollution measures look like. These are plots that show you just where the PM2.5 there on the left and then nitrogen oxides on the right were, and they're the 6 different field centers. The number of dots means how much pollution there is. So those heavily dark dots are all down here. That's Los Angeles, right here. And this is Los Angeles. We looked at it numerically, and you can see PM 2.5, those tiny microparticles, were most abundant in California, not unexpectedly. Nitrogen oxide, most abundant in California and New York. Nitrogen dioxide, most abundant in California and New York. And black carbon, not surprisingly, most abundant in California and New York. So when we looked at the association between these various air pollution measures and coronary calcification, we found that you had black carbon, it didn't matter. But if you had increased nitrogen dioxide, nitrogen oxide, and PM 2.5, you had an increased risk of having increased coronary calcium. And so you can see it as log-term average PM 2.5. Now, when we looked in subgroup analysis, we thought we would find a significant difference between men and women just by virtue of body size. So women and men are exposed to the same concentrations, but for women, the body size is just so much smaller. And while there was some maybe trend, it was not statistically significant because these confidence intervals are so large. So that's what we found with men versus women. But the good news is, over the course of our study, every line here represents one person's monitor. So you can see the lines are all heading down. So via certain, legislation or regulations, air pollution measures were decreasing in our study, and we think that's a good thing. So I just want to finish up by saying heart disease, leading cause of death of women. Much of our knowledge has been derived from studies in men. And despite many similarities, there are also these important differences which we think merit attention. And that's what the research in our center is aimed at. And thank you for your attention, and I'd be happy to answer any questions.
Questions?
Yes.
Cameron.
Thank you for the talk. I have a question about the effect of stress in women. Has anyone studied if treatment of stress with anxiolytics mitigates that risk in any way with propensity-matched individuals?
That's a great question. So the question is, stress increases risk. Can you lower that risk by lowering stress levels with anxiolytics or something? And the answer is no one has looked at that, but we can take a snapshot and think about what probably will happen, thinking about what happened in the depression studies. We know depression is significantly associated with cardiac events. And so in many studies, the thought was, well, if I just lower their depression, treat them with SSRIs or whatever, then that should lower their cardiovascular event rates. And in studies that have done that, like the SAD heart study, they were very effective in lowering their depression scores, but no change at all in their cardiac events. So I think it's a lot more, that would be nice if that was the case. I think it's going to be a lot more complicated than that. And I don't know the answer, but that study is still not done.
Are there any gender discrepancies in the sensitivity and specificity of EKG and markers with regard to picking up active ischemia?
Yes. There's the sensitivity and specificity of every non-invasive test looking at coronary disease, except for imaging studies, like fixed imaging studies like coronary CTA, is less in women versus men. So ECG abnormalities, stress testing, stress echoes, nuclear perfusion, all of those are less sensitive and less specific in women as compared to men. But the CTA has been proven to be equally as sensitive in men and women, and coronary calcium as well. So some of those measures may be more useful for women.
How and why did Barbara Streisand endow your center? What was the connection?
I'm sorry, say it again.
Barbara Streisand?
Say the whole question.
Center? How did she endow your center?
How did she end? Oh, so interesting question. So, yeah, okay. So, Barbara Streisand developed this interest in heart disease about 10 years ago. Fun fact, fun story. Her boyfriend at the time, this is before she was married to James Brolin, had a cardiac event at Cedars, and her cardiologist at the time was Noel Baring-Mers, who's a big cardiologist at Cedars and interested in heart disease in women. So they developed a friendship, and that was how she got her relationship with Barbara and her center at Cedars. About 5 years ago, Barbara came to us and said, I want to do something at UCLA. I want to help you guys start a center and spread the wealth and the love. So she gave us the money to start a center. Yes.
Hi, thanks so much for the talk. Really important stuff that you're doing here. I had a question about heart failure with preserved ejection fraction. So as we know, it's increased incidence in women. Also, there's an increased incidence in patients with diabetes.
Decreased incidence in?
Increased incidence of HFpEF in patients with diabetes. And
yep,
so
absolutely.
And so I wanted to ask you about microvascular dysfunction and its relation to HFpEF, and if there's been...
So you're barking down exactly what our thought processes are about our next research studies, because we think the commonality and the common factor that's going to tie all of this together is microvascular dysfunction, because you're exactly right. The diabetic heart failure that we see, that's going to be the wave of the future. And these are the stiff hearts that they get with microvascular dysfunction. It's the same thing we see in hypertension. It's the same thing we see in heart disease in women. So we think that is going to tie a lot of this together. The problem is we don't have any good way of improving microvascular function. Ranolazine is probably the closest thing we have, which is a sodium channel inhibitor for ischemia, which is probably the wrong run-of-the-mill heart ischemia is probably not the right time to use it, but in microvascular dysfunction, it tends to be very effective. And I think we're going to learn so much more in upcoming years, but you're exactly on to what we're thinking about. And next time you invite me back, I hope we'll have some answers. Yes.
Carol, thank you very much for great talk. Really appreciate your visit. MACE has been an incredibly rich data source, and you've been responsible in large part for much of what we've learned from it. So my question is, how much interaction have you found between race and sex when you look at some of these risk factors and responses to therapy from the MESA data set?
Yeah, that's a great question. So
are the relationships uniform across the 3 groups in MESA or 4 groups in MESA or not?
Yeah, so that was one of the beauties of MESA, is that we could do these subgroup analysis by race, sex, gender, all these things. It turns out we have not found a lot, mostly because once you dice it that much, the numbers get too small. So we've come up with a few things that are interesting and important, we think, by race and sex, but mostly not, to my great disappointment. But part of it may be also that MESA, to get into MESA, you had to be a completely normal, healthy 40-year-old, no evidence of clinical or subclinical disease at all. So that's not a true cohort, because in this country, the unfortunate truth is most of us have atherosclerosis by 40. So it was a healthier than average cohort. And so I think a lot of it is colored by that, but we have not found a lot. Thanks. Hi.
So appreciate your talk. 2 questions. Could you tell us the different names that microvascular disease in women has been called? Because it seems to keep changing. And then I thought I remembered that Dr. Baring-Mers did some research with amitriptyline for treatment of microvascular disease. And could you say if that's correct or not?
So, yes. For the second question, the answer is yes. And no, it did not work. The other question, Syndrome X, microvascular disease, those are the main 2. there's a bunch of others that I can't call right now. Sorry. Probably microvascular disease in my brain, but
Thank you for an excellent talk. You touched on a number of public policy issues, and I was wondering, as an early career investigator, how would you recommend that we can start having at least even the smallest impact on healthcare policy?
so the policy issue is the biggest thing for us, I think. A lot of what we do, we hope to see translated to policy and doesn't. And so I can't explain to you how to make that transition because I haven't cracked that nut myself. But I got to tell you, the data that we see in things like smoking cessation, air pollution control measures, things like that, I think clearly support these measures. And I don't know, in the trans fat ban in New York, all these things support improved health. And so I hope the decision makers are paying attention. I don't have a magic bullet, I'm sorry, but it's important stuff. And I'm looking forward to seeing you carry that forward. Thank you guys so much for your attention. Can I make my flight?
Pardon? Oh, take your mic. No, you can't steal the mic.
I cannot steal your mic.